Hi everyone. When to dialyze my patient and by which method? Under this topic, I'll describe a brief about the acute kidney injury, various methods of the renal replacement therapy, and their evidences in ICU, and lastly, a summary of the topic. Causes of acute kidney injury in ICU is classically divided into the three category. One, prerenal, that is the most important cause of the acute kidney injury in ICU, intrinsic renal failure and obstructive renal failure. Initially, it was considered to be unusual in ICU. Now, in these days, we found it is not so unusual. A rifle criteria is one of the tools to recognize the severity of acute kidney injury, and it is based upon the serum creatinine and urine output. Now in these days, a KIDIGO staging is more popular to recognize to recognition of the acute kidney injury, and it is also based upon the serum creatinine and urine output. Indication for renal replacement therapy in critically ill patient with acute kidney injury is classically divided into the life-threatening indications and non-emergent or non-life-threatening indication. Among the life-threatening indication, metabolic acidosis secondary to the AKI with pH less than 7.1, hyperkalemia, a serum potassium level more than 6 along with the ECG changes, pulmonary edema not responsive to the diuresis or to prevent the need of ventilatory support, uremic complication that includes encephalopathy, pericarditis, neuropathy, and bleeding. Other metabolic parameters may require a renal replacement therapy like dysnatremia, hypomagnesemia with anuria or areflexia. Whereas non-emergent indication requires solute control just to control the urea and creatinine level. However, there is no universally accepted level of urea or creatinine which suggests to start the renal replacement therapy. Fluid removal even in the absence of pulmonary edema just to prevent the fluid overload. Nutrition support sometimes require a renal replacement therapy so that you can accommodate parenteral nutrition volume to the patient. Modified ultrafiltration in patients with cardiorenal syndrome and during the cardiac surgery to decrease the preload can also require the renal replacement therapy. And incorporating the renal replacement therapy for drug delivery and cytokine manipulations in sepsis, though it is now questionable in the present scenario. We can further extend a potential indication of a dialysis or renal replacement therapy in critical ill patient in the form of renal support. And obviously that include the nutrition, cancer chemotherapy, treatment of respiratory acidosis and ARDS, and even just for the fluid management in multi-organ dysfunction. Ideal mode of renal replacement therapy for critical ill patient requires removal of excess fluid and treat fluid overload, correct and control azotemia, correct and control electrolyte imbalance, assist in maintaining acid-base balance, and that too must be accomplished without precipitating additional hemodynamic adversity. Renal replacement therapy can be achieved by peritoneal dialysis, hemodialysis, which is intermittent in nature, continuous renal replacement therapy, and the renal transplant. However, renal transplant is not an actual modality for the renal replacement therapy in ICU. So we will discuss remaining three modality for renal replacement therapy. In peritoneal dialysis, dialysate fluid actually placed in the peritoneal cavity where it remains for the some time, which is known as dwelling time, and during this time a diffusion and convection happens in the form of the removal of the solute as well as the removal of the fluid as ultrafiltrate, and we take out this fluid in the form of effluent. Advantages of peritoneal dialysis are it can be performed in difficult or impossible to obtain adequate hemoaccess. No anticoagulation is required. However, disadvantages, they result into the substantial protein loss, risk of peritonitis, drainage difficulty, elevation of diaphragm that lead to the decrease in the pulmonary functions, hydrothorax, and glucose and electrolyte abnormality. There would be a two aim for the peritoneal dialysis as well as any other renal replacement therapy. One is the solute removal, another is the fluid removal. In peritoneal dialysis, solute removal concept require a more dialysate volume as well as the more dwelling time. Whereas fluid removal concept require the glucose concentration dialysate should be more. That governs actually osmotic dragging pressure, and dwelling time should be less. That result into the more fluid removal. A word about the peritonitis, because it is one of the infectious complication of the peritoneal dialysis. Uh, Actually, the patient complains pain, nausea, cloudy dialysate effluent, and loss of ultrafiltrate. You notice, then you must suspect the peritonitis related to the peritoneal dialysis. And of course, ISVD guidelines to diagnose, manage, and recommendation for the treatment of uh, peritonitis related to the peritoneal dialysis. However, this modality as a renal replacement therapy is not really advocated because there is so much load in the critical ill patient, and this modality is not able to really bear that load, so that peritoneal dialysis is not considered to be a first-hand renal replacement therapy in ICU. The next modality is the hemodialysis. Of course, it requires some form of the conduit, either temporary or permanent. Temporary is a double lumen catheter placement in the vein, especially central vein, and a permanent conduit would be a AV fistula in the hand. This is a circuit diagram of a typical hemodialysis where one pressure is monitored as an arterial pressure head. Before pump, it is actually a negative pressure created by the pump. It is called as the arterial pressure. And second pressure just before the blood entering into the dialyzer. This is called the dialyzer inflow pressure. And the third pressure is actually venous pressure before blood is going to enter into the circulation. These three pressures are important, and we subsequently know what are the importance of these three pressures. This is a schematic diagram of the filter. How does it look like, and what is the actual structure of this filter? When we just see its cut section, it's actually there are so many small capillaries or the unit of the dialysis surface, and it is the blood actually flow in these small tubules, and the dialysate fluid actually present around these tubules, and it flows in counter current direction, that is opposite to the blood flow direction in this dialysate filter. It can be a hollow fiber, it can be a plate fibers. A membrane material is also important. It can be a cellulose, substituted cellulose, cellulose synthetic hemophane, and synthetic made of the non-cellulose material, that is a polysulfonate and the polymethyl methacrylate. These are the common material which we are using nowadays. Why this material is important? Actually, this material is responsible for the what you call is the bioincompatibility or biocompatibility. How this material is actually react to the body, a cascade of the SIRS or inflammatory marker that actually determine the bioincompatibility. So the material, if it is causing a less activation of the complement, coagulation cascade or leukocyte, that is a more biocompatible. Cellulose membrane is the least biocompatible. That is, it induces a cascade of the complement and coagulation, whereas synthetic material is the most biocompatible and modified cellulose in between. So therefore, in the CRRT, we must select a synthetic material, because in CRRT that material will be in uh, uh, continuously, it will be exposed to the patient's blood all the time. So there is a more chances of bioincompatibility if the material we select a semi-synthetic. Sequelae of the effect of bioincompatibility would be prolongation of renal damage, greater tendency to filter clotting, prolongation for impairment of pulmonary gas exchange, hypercatabolism, increased risk of infection also. So therefore, as I told you, in CRRT, use either substitute cellulose or synthetic cellulose. Dialysis fluid. These are the various types of the dialysis fluid: bicarbonate, acetate, lactate, citrate. Citrate is having an additional advantage of anticoagulation along with the bicarbonate donor. Bicarbonate dialysis fluid is more physiological anion. Instability is problem. Calcium and magnesium precipitated as carbonate when sterilized with buffer, and apparent predilection to the bacterial growth. Whereas acetate causes the respiratory and vascular complication in the form of vasodilatation, myocardial depression, and increased oxygen consumption. Therefore, we almost now in these days, we never choose the dialysis fluid of the acetate based fluid. Lactate undergoes hepatic conversion to bicarbonate on equimolar basis, and it should be avoided in the lactic acidosis, hyperlactatemia, and hepatic failure. Now we move on to the anticoagulation part of the renal replacement therapy. Our choices for anticoagulation are the heparin, low molecular weight. So anticoagulation, which requires in renal replacement therapy, and the more important in the continuous renal replacement therapy. The choices are heparin, low molecular weight heparin, citrate, prostacyclin, hirudin, serine protease inhibitor. A regional heparinization is sometimes required especially in the CRRT, where we don't want a systemic heparinization, where the pre-filter heparin infusion is there and post-filter protamine infusion will be there to neutralize the heparin. Now we move on to the what are the physical properties or physical processes happens during the dialysis, or what is precisely called the renal replacement therapy. So first and foremost is the ultrafiltration. What is the ultrafiltration actually? Ultrafiltration is movement of the solvent from high pressure to low pressure. It moves across the pressure gradient. You can see blood is flowing in the one chamber, and there would be a waste product is there, and it happens transmembrane, and the governing pressure would be your hydrostatic pressure. That is the governing force, how much ultrafiltration should happen. And what physical property happens here is the convection. So convection is the movement of solvent from high pressure to low pressure across the membrane. And who determines the amount of the solvent and the type of the solvent? One is the pressure gradient, and another one is the sieving coefficient. The sieving coefficient is the ability of solute to convectively cross a membrane. The ratio of solute concentration in the ultrafiltrate to the concentration in the plasma is actually a sieving coefficient. So if sieving coefficient is 1, That means everything is filtered out. Whatever concentration present in the ultrafiltrate is having the same concentration of the plasma. And sieving coefficient 0 means nothing is coming out. So ultrafiltrate concentration 0 and plasma concentration is whatever that solvent was having. So based upon that, this mode of the renal replacement therapy, what we call the slow continuous ultrafiltration, this is a ray diagram. From the patient, this pump is drawing the blood and it is returning to the patient, and another pump is actually creating a negative pressure across the membrane and the fluid is collected over here. That is the ultrafiltrate fluid as well as the effluent. Effluent, we use the word what is coming out from the dialysate membrane, and here is the effluent is equal to the ultrafiltrate because nothing is there in the reference fluid, and this is called slow continuous ultrafiltration. If the next important thing, if we combine this ultrafiltration along with the replacement of fluid, this is called the hemofiltration. Actually, a large amount of the ultrafiltration is happening, and the equal amount of the whatever ultrafiltrate happens, equal amount of the fluid enters into the patient circulation in the form of replacement solution. This is called hemofiltration. So process is the same, convection. Ultrafiltration is happening across the pressure gradient from high pressure to low pressure, but the amount would be large, and the same amount of ultrafiltrate will be replaced in the patient circulation in the form of the replacement solution. This is called hemofiltration. So hemofiltration is equal to, like a mathematics, ultrafiltration plus replacement fluid. And how we can really depict on the CRRT mode from the patient and of course to the patient, and here one more pump actually infusing the replacement fluid, and here is the ultrafiltrate is happening. Again, nothing reference fluid, so that effluent is equal to ultrafiltration, and here large amount of ultrafiltrate will be there, and the replacement fluid we can administer to the patient. But we should keep this thing in mind, we can replace this replacement fluid either before the membrane or after the membrane, and definitely it goes into the patient circulation. If it happens before the membrane, it is known as the pre-dilution, and if it happens post membrane, it is known as post dilution. And this is the ray diagram which is showing a pre-dilution. Here you can say the violet color of replacement fluid entering into the patient circulation before the membrane. Therefore, it is a pre-dilution. Advantage of the pre-dilution is the decreased risk of clotting, because there is a more a fluid will be there. Definitely blood will be diluted with this replacement fluid in the membrane, and higher UF capabilities require decreased hematocrit in the filter. Whereas this is now your replacement fluid is the after the filter, here or here, just before entering into the patient circulation or just immediately after the filter. Both are the post filter or post dilution, and there is it actually results in the lower replacement rate because filtration fraction would be more. Higher blood flow rate is required, higher anticoagulation is required, because now the blood is in the form of the high hematocrit in the membrane in comparison to the pre-dilution. Now in these machines you can fractionate. Even a same patient you can give a 50% pre-dilution, 50% post-dilution, or maybe a 75-25. This provision is now all the new machines are having. So we understood the ultrafiltration, we understood the hemofiltration. Next physical property we need to know is a diffusion. Diffusion actually movement of solute. It's not a solvent, it's a solute from an area of higher concentration to an area of lower concentration across the semi-permeable membrane. So it is not a pressure, it is a concentration gradient. So you can see there is a many white dots. Here is no white dots. Over the time period, the distribution happening. Now both the compartment is having a equal number of white dots. That is the equal equilibrium of the concentration. This is called diffusion. In fact, this process is happening in dialysis. In the ultrafiltration, the convection is happening. In dialysis, actually, diffusion is happening, and the movement of the solute across the a concentration gradient in through the semi-permeable membrane. So how does it look like in the hemodialysis? One reference fluid be there, must be there. That is the principle of the diffusion. So green color is the reference fluid, and your red is the blood, and white dots you can consider as a solute, and the solute is moving across the concentration gradient. It is not a pressure over there, and of course to have a more contact period, there is a counter current movement of both these fluid, blood flowing from above downward, and fluid, that is a dialysate fluid, moving from below to the upward part of the membrane. And this happening here, the diffusion is happening during the hemodialysis. This is the typical hemodialysis. How does it look like in the CRRT ray diagram? From the patient, this pump is withdrawing the blood, and it is, of course, this pressure, same pressure is actually going towards the patient. One more pump is there. It's actually uh, uh, this pump is used for the movement of dialysate in the filter. So this is going into the filter, whereas the previous one, replacement fluid, was going into the patient circulation. Here it is going into the filter, and it is coming out through this negative pressures pump as a effluent over here. It can act as a ultrafiltration also. Diffusion almost always happening with the ultrafiltration also. So dialysis also having along with the ultrafiltration. So this effluent now having a ultrafiltration plus equal amount of diacylate. So therefore, in the ultrafiltration or hemofiltration, your effluent is equal to ultrafiltration only. Whereas in the hemodialysis, the effluent is equal to dialysate volume plus ultrafiltration volume. Suppose your dialysate rate is 1 liter per hour and you are making the patient is 50 ml per hour. So your effluent volume would be 1050. We can combine all these things together. Of course, hemodialysis always combined with the ultrafiltration, but you can combine with the hemodialysis, ultrafiltration, along with the hemofiltration. Replacement fluid you can give. So all these three activity can happen. This is called the hemodiafiltration. So from here you can take the blood from the patient, goes to the blood. Here simultaneous, because I use the dialysate, so that hemodialysis is happening. This is the reference fluid, and whatever ultrafiltrate are happening, replacement solution is also going on. So both the things are happening here, convection as well as the diffusion. Convection from high pressure to low pressure, responsible for the ultrafiltration, and we are replacing the equal amount of fluid, that is a hemofiltration, and movement of the solute from high concentration to the low concentration, diffusion happening, and dialysis also happening. That's why it is called hemodiafiltration. The ray diagram of this continuous veno-venous hemodiafiltration, what we commonly use as CVVHDF. So from the patient, and of course you require one more pump. If you don't require the replacement fluid, then the one pump is good enough. But now you require a one more pump for the replacement. So large amount of ultrafiltration is happening and you are replacing the fluid. Along with you require a dialysate. So one more pump will be there, and there is a counter current movement of this fluid to the blood. So it is from above downward, this is from below upward, and here. So again, This effluent will have volume of ultrafiltrate as well as the dialysate, and all these things happening simultaneously: ultrafiltration, hemodialysis, and replacement fluid. Therefore, it is called as a hemodiafiltration. Just combining all this thing together rapidly, we can revise from patient to patient in only ultrafiltration. This is called the SCUF, slow continuous ultrafiltration. From the patient to the patient, ultrafiltration happening, the equal amount of the fluid is actually going into the patient circulation. This is called the hemofiltration. From the patient to the patient, and reference fluid in the form of dialysate going into the membrane and the effluent coming out from the membrane. So this is called continuous hemodialysis, CVVHD. And putting all these things together, then from the patient to the patient, replacement fluid in the patient circulation, and dialysate in the dialysis membrane, and the effluent is coming out. This is called the continuous hemodiafiltration. So in the CVVH, convection predominantly happens. Not only predominantly, only convection happens. CVVHD, diffusion is happening along with the convection, small part. CVVHD is convection and diffusion, the equal amount of their SCUF, completely a convection, ultrafiltration, and HDF is the convection in the diffusion because you take the ultrafiltrate also. A word about the transmembrane pressure, commonly used for the our determination of the ultrafiltration. This is actually an average pressure of the membrane across the membrane. So it can be calculated as filter pressure plus return pressure, pre-filter, post-filter pressure, average of these two, and reduced by the effluent pressure. So that is the transmembrane pressure, and that is the primary factor determining ultrafiltration rate. Similarly, we can use the pressure drop as an indicator for the your clotting of the membrane. So if pressure is very high, of course this is a little bit higher pressure when entering into the membrane, and the downside side pressure, that is the venous pressure, is having a little bit drop in the. If this drop is too much, that means this membrane is having some clotting in their filaments, in their tubules. So that therefore the more resistance, and the after the membrane there is a less pressure. So this pressure drop increase actually helps for the recognition of the clotting of the filtration. Now it comes to what are the things are really removed by the renal replacement therapy from the dialysis or from the hemofiltration. But the basic thing to recognition for this is what are the molecule size. And typically the albumin, beta 2 microglobulin, inulin, they are having a large size. Vitamin B12 is having a middle one, and the small one is your urea, potassium, phosphorus, sodium. Therefore these things cleared off very well in any type of the renal replacement therapy. So just to have an idea how the things works when we perform the renal replacement therapy. So for the diffusion, of course, the small molecule clear off rapidly. As the size of molecule increases and you want to really clear off, then you require a convection property, that is your ultrafiltration or hemofiltration. So therefore the middle and little bit a larger volume require a convection, and after that maybe adsorption only, and up to a certain level you can remove a larger protein molecule. You cannot remove the renal replacement therapy. Continuous renal replacement therapy, just a kind of a diagram over there. How does it actually in the practice? We can use a pump going for the membrane, and of course the machine and the pump for the return over there. This is a nutshell to compare with the intermittent hemodialysis, SLAD, SCUF, CVVH, CVHD, CVHSDF. The basic thing is the blood flow rate, as well as the replacement fluid level, which is require a very high ultrafiltrate. Now coming to the timing of the CRRT, early versus late. Two trial, LN and AKI trial. That first trial is actually where the primary endpoints are 90 days mortality. In the next one is the 60 days mortality. In the LN trial, it shows a early intervention therapy. There is a little bit of mortality benefit, whereas the AKI trial is not actually result into the decrease in the mortality. That shows the equal result in terms of the mortality as well as the recovery time from the renal failure. So still this thing is not settled very well. Early is better from the late or not. Now dose of CRRT. Whenever we say dose of CRRT is applicable to the continuous veno-venous hemofiltration only. It is not for the dialysis, it is a hemofiltration. How much dose for your filtration, how much amount of replacement fluid is required. Based upon that, dosing is actually, and so many studies has been done, and they studied the different regime of the doses, 40 ml per kg versus 25 ml per kg, and a very famous study, that is the Ronco et al, actually studied these three dose regime: 20 ml, 35 ml per kg per hour, and 45 ml per kg per hour. This is the amount of the replacement fluid for the hemofiltration, and he found definitely advantage of the 30 ml per kg per hour over the 20 ml, and above that there is no additional benefit. So with this study, they concluded 35 ml per kg per hour would be an optimal dose. Advantages of using CRRT: it is suitable for use in a hemodynamically unstable patient. Precise volume control, which is immediately adaptable to changing circumstances. Rapid control of metabolic acidosis and hyperkalemia. Improved nutritional support. Available 24 hours a day with minimal training. Safer for the patient with the brain injury and cardiovascular disorder, particularly diuretic resistant CHF. May have an effect as an adjuvant therapy in sepsis, and probable advantage in terms of renal recovery. These all are the claimed advantage of CRRT, but when we really analyze the evidence, there is not much evidence for all these advantages. And disadvantage, obviously, is expensive. Anticoagulation is required because around the clock you require extracorporeal circulation, risk of line disconnection, hypothermia, severe depletion of the electrolyte, particularly phosphorus. Now, when we review the literature over there and the continuous versus intermittent renal replacement therapy for critically in patient with the acute kidney injury, they concluded the numerous issues related to the study design, conducted, and quality, and dispute the validity and the questions any inference that can be drawn from these trials. The context of these limitations, the initial RRT modality did not seem to affect mortality or recovery to the RR independence. So they require a more meta-analysis over there. The subsequent meta-analysis shows that there is no great advantage of the CRRT over the intermittent. So n number of the studies has been done, and finally this Cochrane analysis, they concluded CRRT offer no survival advantage over the intermittent RRT in the patient with acute renal failure. At that time it was used. Patients surviving acute renal failure who are managing with the CRRT have a similar expectation of recovery of renal function as those treated with the intermittent RRT. CRRT associated with the significant higher mean arterial pressure. So this is very sure. Relatively, they are having a more blood pressure during the renal replacement therapy, and CRRT associated with the significantly increased risk of recurrent filter clotting compared to the intermittent RRT. So what could be a solution for that? The hybrid therapy may be best. The feature of hybrid therapy. What is the hybrid therapy? Nephrology hemodialysis machine rather than the critically care CRRT machine is used here. deliberately intermittent rather than attempting to be continuous. Treatment session during longer than the conventional IHD, like 4 to 6 hour conventional. Here we can go up to the 8 hours, 10 hours kind of. Solute and fluid removal slower than the outpatient maintenance hemodialysis, but faster than the CRRT. So this is the hybrid over there. So we can combine the pros of these two modality. What is the pros of the CRT? Allowed fluid removal with minimal hemodynamic stability, consistent solute control, independence of availability of trained hemodialysis staff. So again, here you can remove, and ISD is inexpensive, intermittency and downtime allowing of the out of the patient for the procedures, can treat more than one patient with one machine. So we can combine, because we use the conventional hemodialysis where the CRRT one machine for the one patient. Here we can treat the patient more than one because intermittent in nature. So we can combine both these things. So in summary, although no formal evidence has shown superiority of CRRT over IR intermittent renal replacement therapy, CRRT has become the standard of care in the management of a hemodynamically unstable patient with the AKI. Higher sensitivity therapy offer no significant advantage over low intensity therapy in critical ill patient, that is the dose of hemofiltration. Controversy remain about the timing of CRRT. Latest trial have added to the existing dilemma. Newer technology has been advocate for the management of the however currently there exists little evidence for use of the same in the sepsis. CRRT affects concentration of drugs and cleanliness with different effect in different modalities. Caution needs to be exercised in prescribing as no standard method yet devised. Underdosing of antibiotic over prevalent may contribute to poor outcome in sepsis, lead to the microbial resistance. Citrate anticoagulation preferred where no contraindication for anticoagulation exists. A dose of 25 to 35 for hemofiltration appears to be reasonable. So with this, there is a constant burning issue also, who should actually govern the renal replacement therapy process? Should be a nephrologist or intensivist. So in specialty directed management, where the clinically specialty is there and they both these two domain work separately, there is a less interaction, where is now proposed a mechanism to do is the comprehensive management, where both the specialty is overlapping predominantly for a patient centric and more interaction, especially in the less severe cases, a moderate interaction, more severe there is a high interaction for the renal replacement therapy, as well as the holistic approach for the comprehensive. So this will lead to a optimal or a better outcome when it comes to a AKI and the renal replacement therapy in the ICU patients. With this, thank you.